Welcome to the session on relevant topics in non-invasive imaging. My name is Rob BEANLANDS. I'm the president of ASNC, American Association of Cardiology. I'm also from the University of Ottawa in Canada.
Boa tarde a todos. Sou CLAUDIO MESQUITA, sou professor da Universidade Federal Fluminense e estou muito feliz pelo convite. Tenho certeza que essa atividade será muito interessante para todos.
Good afternoon. Thank you for the invitation, Vitala. It's a beautiful congress. Thank you. And I'm GLÁUCIA MORAES. I come from Rio de Janeiro, from Federal University of Rio de Janeiro.
Our first speaker is Dr. Andrew EINSTEIN, who is a cardiologist, professor of medicine from the University of Columbia, trained at Princeton University and the Mount Sinai. Andrew EINSTEIN will be presenting on minimizing radiation exposure in medical imaging.
Okay. Thank you, Dr. BEANLANDS. Thank you, chairs. Thank you to the meeting organizers. Really a pleasure to be here. So why has radiation exposure become such a concern in cardiology and medicine? You can see here statements from all of our leading cardiology professional societies. American College of Cardiology, European Society of Cardiology, American Heart Association, our specialty societies, ASNC, which Dr. BEANLANDS is president of, SCCT, Society of Nuclear Medicine. Everyone is paying attention to this. I think the reason is because, and perhaps this was more frequent a decade ago, but there's still many patients who receive very high doses of radiation from cardiac testing. On the left, you can see an illustration of a gentleman who received 10 years of background radiation or more, who had myocardial perfusion imaging. On the right, a woman with shortness of breath who received a similar dose of radiation. Both of these are recent studies, one from nuclear, one from CT. In the INCAPS study, a worldwide study, which many of us here have been participants in, we've seen that while you have these outliers, many patients receive much lower doses, and there's wide variability in the amount of radiation to which patients are being exposed from cardiac testing. This is illustrated in particular in Brazil. Whoops, you can. This is illustrated in particular in Brazil. You can see here from the INCAPS Latin American study led by João Vitola. Radiation doses in 9 institutions in Brazil. 2 of them met the ASNC guideline of being less than 9 millisieverts. These institutions are not identified in the paper, but I will point out that one of those 2 doses, the low doses, is in Quanta. But other patients, other institutions, people are receiving much higher radiation doses. So there's the opportunity to really lower radiation doses, wide variability. So what we should do is apply our principles of radiological protection. These are identified internationally by the International Commission on Radiological Protection as justification, optimization, and dose limits. Justification is doing the right test for the right patient at the right time. Optimization is doing it the right way. Often we call this ALARA, and dose limits is something which we apply to ourselves and our staff, but not to our patients. We don't want to limit the procedures patients receive just because they've had previous tests. Let's talk about justification briefly, then optimization. Really, the practical implementation of justification is through the use of appropriateness criteria or appropriate use criteria. The 2 largest sets of these for cardiac imaging derived from the American College of Cardiology and the American College of Radiology. There's slightly different approaches for both of these. There's many documents which have been issued. You can see here the timeline of appropriate use criteria from the American College of Cardiology. About 1 document is issued per year, and the American College of Radiology is constantly introducing new documents. The general approach uses an approach developed by the RAND Corporation, a so-called modified Delphi approach, and develops different appropriateness criteria and comes up with an algorithm. Here's an example, a hierarchical testing for myocardial perfusion imaging. Is it a preoperative assessment is the first question we ask. If that's the case, then we have a little bit of a little flow chart here. If it's low-risk surgery, then it was an inappropriate test. If it's intermediate risk, then it depends what the patient's functional capacity is and what their risk factors are. Let's say it's not preoperative assessment, then we can move on in the algorithm. Say the patient has had prior PCI or CABG. If that's the case, we've got another flow chart. If it's prior PCI and it's less than 2 years since that PCI, inappropriate test. Prior CABG, less than 5 years, we call it uncertain. But if it's more than 2 years for PCI, there's a stronger indication, or more than 5 years for CABG. We can move on in this flow chart. Does the patient it's not preoperative assessment, not prior PCI or CABG, but the patient has ischemic equivalent. That is, they have chest pain or dyspnea, which is concerning for coronary artery disease as being a cause. Then it depends whether it's acute or chronic chest pain, what the pretest probability of disease was, and the patient's ECG and ability to exercise, and that determines what is an appropriate test for those criteria. By applying these appropriate use criteria, which come not just in this flowchart form, but in terms of individual line items, we can determine whether a test is appropriate, inappropriate, or uncertain. There have been many studies of appropriateness, one multi-center study of over 6,000 patients in 6 practices, all in the United States. They determined appropriateness at the point of service, made a computer-based classification, and found that about 2/3 of studies are appropriate, and another 1/6 are inappropriate, another 1/6 are uncertain. This varies from practice to practice. While in many studies we've seen similar values, there are some outliers. You can see on the bottom row here, in a center in Chicago, 45% of studies were inappropriate. It's important for us to keep track of appropriateness, make sure that the vast majority of patients meet appropriateness criteria. The second principle is optimization, doing it the right way. We want our tests to be done with radiation as low as reasonably achievable. There are many cardiovascular procedures which contribute to the high cumulative effective dose which we've noticed in some populations. In fact, in this one study of about 1 million patients from the United States, which I was privileged to participate in, we found the highest dose from any individual procedure was from myocardial perfusion imaging. That was followed by 3 different types of CT scans and cardiac catheterization. So certainly in cardiology, we need to be very concerned about dose optimization. We've got a number of optimization strategies to minimize radiation doses in accordance with the ALARA approach, both in nuclear cardiology and cardiac CT. In nuclear cardiology, we need to know the dosimetry of competing protocols. In general, this will prefer the use of technetium-99m-based agents rather than thallium whenever it's possible. Here from the International Commission on Radiological Protection is a figure illustrating effective doses from different cardiac procedures. In practice, across modalities, with the possible exception of PET, we see there's tremendous variability in radiation doses. In SPECT myocardial perfusion imaging, in coronary CTA, in invasive coronary angiography, again illustrating the potential for dose lowering. We should consider the necessity of each radiation dose injected and consider stress first and stress only myocardial perfusion imaging as a protocol for patients who have a low pretest probability or even an intermediate pretest probability of having a stress defect. The largest such study is from Texas Heart, about 16,000 patients with normal SPECT. Half had stress and rest imaging, half had stress imaging alone. And you can see that the prognosis of the 2 groups was really identical in nearly 5 years of follow-up on mean. However, stress-first imaging is not used widely across the globe. You can see this figure, as of yet unpublished from INCAPS. In Brazil, between 25 and 50% of studies are performed with stress first, followed by rest imaging. I think we can increase that percentage and potentially perform stress-only imaging. My understanding is that the reimbursement system in Brazil currently pays you half as much or so if you do only stress imaging. So that may be something to work on the system here for, so that patients can benefit from the real dose lowering afforded by stress-only imaging. We should minimize activity to that needed to obtain good image quality with a high degree of confidence. We should consider lower activities in smaller patients, that is weight-based dosing. And we should use technological advances to reduce radiation doses. We have improved image reconstruction algorithms, which incorporate iterative reconstruction, resolution recovery, and noise reduction. And in this study from Gordon Dupuy, we find that half-dose imaging performed using this advanced image reconstruction approach is associated with better image quality than a standard dose approach using more conventional image reconstruction. We have technology on the hardware side, both high-efficiency CZT SPECT systems and insofar as it's possible to incorporate, PET is really the lowest dose and the most accurate test if that's possible. My understanding is that it's difficult to obtain tracers for cardiac PET in Brazil, but certainly one can incorporate CZT into their practice. Whereas a traditional Anger camera is based on an array of photomultiplier tubes coupled ultimately to scintillators, which scintillate after being exposed to a gamma ray. A CZT camera is based on a high-efficiency array of solid-state detectors made of cadmium, zinc, and telluride alloy. Anger cameras will typically have 2 detectors, whereas these high-efficiency cameras will have anywhere between 9 and 19 detectors, which are crowded around the heart, making them more efficient, and hence the name in terms of detecting scintillation events or decay events, more precisely, in the heart. In the millisievert study, my colleagues and I compared image quality, myocardial perfusion between patients undergoing 1 millisievert imaging using a high-efficiency camera and more conventional imaging. We found on average image quality, as you can see here, was better in the top row in high-efficiency SPECT in comparison to the conventional camera. That 1 millisievert high-efficiency SPECT, half of patients were rated as having excellent image quality on blinded reads, whereas for the standard Anger SPECT, only a quarter of patients. However, the summed rest score was strongly correlated between these approaches, as was total perfusion defect and ejection fraction. In another study, we looked at prognosis of 1 millisievert SPECT, and we found excellent outcomes for emergency department patients presenting who had stress-first imaging using a 1 millisievert injection. So I think the benefits of this technology are great, and we should really be using it more. If you take a look here, this data is from 2013 at CZT camera use across the globe. None was being used in Brazil as of 2013. So I hope some of the leading centers in Brazil will start to adopt this technology. If we look at PET use across the globe as well, and that's even lower radiation doses, again, PET myocardial perfusion imaging, as of INCAPS 1, was not being used in Brazil. We're planning INCAPS 2 for 2020. I hope all of you will, who do nuclear cardiology or cardiac CT will be able to join us as participants in this study, and we'd like to see how people are practicing then. For cardiac CT, we also have a number of optimization strategies. As with nuclear cardiology, appropriate case selection is critical. In cardiac CT, there are big differences between scanners as well. The first generation 64-slice scanners only enabled retrospective helical scans. Those were really the Model Ts. We shouldn't be using those scanners anymore. We've got much better scanners to use in 2019, which have lots of technologies. For example, prospectively triggered scan modes, reduced X-ray tube potential, and iterative image reconstruction. And if you're using a scanner which doesn't incorporate those, really one should think about upgrading that. However, it's not just the scanner which we have, but how we use that scanner. You can have the greatest technology, but if we're not using it well, you know, it results in such an unfortunate situation. So we need to be using our technology the right way as well. Patient preparation is important. We need to control patients' heart rates. Beta blockers, calcium channel blockers, reducing the heart rate enables us to use prospectively triggered scan protocols, high-pitch helical protocols. It improves dose reduction in ECG-gated tube current modulation for retrospective scans, and it helps us avoid very high-dose scan modes. Another method of patient preparation is breast retraction, a simple approach but which is rarely used. In some scanners, there's a Velcro patient positioning strap. You can use that to retract female patients, particularly breasts, outside of the scan field of view, really lower the radiation dose to the breasts, and reduce the risk from that scan to your women patients. Very important. Appropriate examination conduct. We should have personalized protocols which should reflect a patient's age and gender, their comorbidities, their habitus, and the clinical scenario. The risks of radiation to men and women are certainly different, and to younger patients and older patients, and this should be reflected in our scan protocols. Scan modes, we've got a number of different scan modes we can use. The older scan modes were helical scan modes, which left the X-ray tube on for a number of cardiac cycles in a row. Now we've got lower dose scan protocols, prospectively triggered step and shoot protocols, or even better volume and high-pitch helical scan modes. Those lower radiation dose even further. We've got multi-center randomized trials which demonstrate consistent image quality while with greatly reduced radiation dose with each of those. So we should really be using these different scan modes. I think I'm running low in time, but one should consider using advanced iterative reconstruction methods. This can lower radiation dose by 80%. In some, we've got many tools in our toolbox to lower radiation dose, both from nuclear cardiology and cardiac CT. Now let's go ahead and use them.
Thank you, Dr. Einstein. Join us, please. Yes, you can. Okay. And it's a great pleasure to introduce Dr. Leslie Shaw. She's from Cornell University and one of the most cited researchers in the world. She's talking about best approach to investigate ischemic heart disease in women. Thank you
all for staying here this afternoon, and I appreciate you. It's such a lovely day that you're spending it with us and not being outside. Lots to talk about, difficult subject. So let's just, the question is basically, which test would you choose? And I'm going to tell you that they're both good, and you're going to say, well, you didn't answer the question. But actually, the timing is not whether you do a physiologic test or an anatomic test, is when you bring the other type of test in with that other procedure. So if you start with a physiologic test, if that's what you're most comfortable with, when would you bring in an anatomic procedure? The point that I would like to make with regards to women and heart disease is that we have to start thinking about imaging as probing relevant biology, answering biologic questions, as opposed to specifically just trying to do a procedure on a patient and I know that from speaking with many, many people in this room, of course you think very thoughtfully about these evaluations. But I think that's the best answer that we have, is to probe the relevant biology, because we have really an ever-increasing body of evidence. And here's just two illustrative papers, one from Quanta, that I use all the time. I'm not just doing this because you're in the front row, Joe. So I cite this all the time because it's an important, diverse patient population. And we have just a robust evidence base on the prognostic value of myocardial perfusion SPECT in women, not only just in general in women. Another critical message is that we don't just have one phenotype of women, we have many phenotypes. We have Brazilian women which have different characteristics, are brought up differently, have different urban versus rural environments, perhaps different means of transportation, more walking, et cetera, all kinds of factors which could change their risk factor profile. And here we see on the bottom slide, African American patients, women from the United States, Hispanic women from the United States, and Caucasians, all with slightly different risk profiles. But the validation of these results across all diverse populations of women are extremely important for us to understand that that a normal SPECT study is associated with a low risk, and as the extent and severity of perfusion abnormalities increase, so does the expected event rate in the population. Not much PET here, but I think it's important for you to realize is that there are now several very large series of myocardial perfusion PET. I actually we did this paper with Dr. BEANLANDS and others, but you can see some data on risk stratification in a relatively large sample of women undergoing rubidium PET imaging, showing this nice ability to risk stratify based upon the PET imaging findings. Certainly PET has distinct advantages, at which Dr. EINSTEIN talked about: better image quality, spatial resolution, a decrease in the prevalence of artifact, including breast tissue artifact, but also an excellent ability to risk stratify. And in many cases, the risk stratification is improved in women over men. So you're going to get higher relative risk ratios for women versus men, showing the value of imaging and also creating a better safety profile with lower radiation, as Dr. EINSTEIN emphasized. So another piece of this puzzle, and interestingly enough, and this is one of the reasons why I talk about probing relevant biology, there's a lot of focus on the coronary microvasculature. You can see the coronary angiogram to the left here, if I can get this. Well, you can see the angiogram. Everybody knows what it is. On the right is a cast of the coronary microvasculature. So we think about the major epicardial arteries, but look at the number of vessels with the coronary microvasculature. There's a hypothesis that women have more underlying coronary microvascular dysfunction. There's a nice review in European Heart Journal recently talking about reduced flow reserve contributing to microvascular ischemia and perhaps contributing to myocardial injury and fibrosis, diastolic dysfunction, the onset of symptoms, and heart failure, and an increase in major cardiac events. Now, Paolo Camici from the UK did a lot of seminal work on actually typing coronary microvascular dysfunction. We are going to be talking mainly about coronary microvascular dysfunction in women who largely do not have obstructive coronary disease, but certainly coronary microvascular dysfunction can occur in the setting of non-obstructive disease, normal coronaries, so epicardial atherosclerosis as well as obstructive disease. That's which makes it very, very difficult for us to figure out in terms of what is causing what. But we can actually measure this with PET. So even though you don't have these tools available, certainly there's a lot of active work on doing flow reserve with SPECT imaging. I think you'll see that become more and more common. But one of the nice things about flow reserve is we're able to look at not only flow within the epicardial coronary arteries, but in the microvasculature as well. So we're able to measure stress and rest. I'm only going to go through this rather briefly because Dr. RAFFAELE GIUBBINI is going to go through that next, so I don't want to steal his thunder, but I'm just going to tell you that evidence of a reduced whatever you want to call it, coronary flow reserve or myocardial flow reserve, I specifically like myocardial flow reserve, but you can call it whatever you'd like, is being documented as a means to identify patients potentially, it's not a definitive, but a potentially having coronary microvascular dysfunction. Some seminal work, again from Viviane Tecchetti, who was born in Brazil, I think moved to the United States when she was 7, if I'm not mistaken. So one of your colleagues who's at the Brigham and Women's Hospital has done a lot of seminal work in this area, showing, interestingly enough, if you look at this figure to the left, that a low flow reserve was associated with the increased risk in women more so than men. And you say, well, that's okay. It's just a unique sample of women. But it's interesting because those women were much more likely to have non-obstructive disease. So this fits into those two categories of type 1 or type 2 coronary microvascular dysfunction, which Paolo Camici talked about in several of his reports. So non-obstructive disease more common in women and more likely to be associated with a reduction in coronary flow reserve, or myocardial flow reserve. Now, there's a wonderful paper that Carl Pepin, who was a past president of the American College of Cardiology, wrote a couple years ago in JACC. I actually am on the ACC's Cardiovascular Disease in Women Committee, and you can't read this, so I'm going to blow this up for you. So one of the unique things that we're looking at is developing a sex-specific signature, or how women may uniquely develop atherosclerosis or be at risk. And one of those signature checklists is that women are much more likely to have non-obstructive disease. You know this all the time. And increasingly, the other message that I'd like to tell you is that you can get ischemia in the setting of non-obstructive disease, and it is real ischemia. And you can get a reduced flow reserve in the setting of non-obstructive disease, and it's a real phenomenon. So we're seeing that women can manifest ischemia not necessarily with a focal obstructive stenosis. They do so at a younger age. They can have preserved LV systolic dysfunction. There may be a different etiology for their atherosclerosis development, and there are often multiple mechanisms for ischemia, like hypertensive heart disease, smaller lumen sizes, all of which can increase the prevalence of ischemia. Now, you can see here from all of these papers, tons and tons, I could have put 50 papers on here. Women have more non-obstructive disease, whether it be from cath, whether it be from coronary CTA. You're going to see more non-obstructive coronary disease, as Dr. Pepin highlighted in that paper. And for the next part of this talk, for the next few minutes, I'd like to talk about some stages and some different parts of stages of atherosclerosis. Actually, Marcio Bittencourt, who's not here, and I are working on this staging of atherosclerosis for a position paper for Society of Cardiovascular CT. It starts here with the detection of coronary calcium. It moves on up to the detection of very high-risk multivessel disease. But let's just look at coronary calcium. Everybody's familiar with it. I'm going to go through this slide rather quickly. You can see a calcium score, which is just basically the product of the area of calcified plaque by the density of that plaque. You can see some nice illustrative examples. Here's on the far right is somebody with a lot of calcium. On the upper left, somebody with no coronary calcium. But what's really interesting is you can look at the prevalence of atherosclerotic plaque in a very large population. This is from the Calcium Consortium. This is a paper that I published last year. And you can see the onset of increasing prevalence of coronary calcium about 10 years later in women versus men. Obviously, a loss of endogenous estrogen as that woman enters menopause increases the prevalence of plaque. And men actually have an increase at around age 35 and greater. But what's really fascinating, where I just went, wow, is if you look at the results from this. Now, this is long-term cardiovascular mortality. This is 15-year mortality from the Calcium Consortium. If you look at patients that have 2 or 3 or 4 vessel calcified plaque, women have a higher mortality than men. So that given area of plaque, this is not brain surgery, all of you know this, a given area of plaque covering a smaller artery is going to encumber more of the epicardial coronary arteries and increase risk, more so in women than men. Fascinating. So we have to start peeling this onion and thinking more strategically about some of our findings. And this actually illustrates the fact that we have to consider arterial size. We have to actually be more sophisticated in our analysis of some of our characteristics. But when you see a calcium score, think in that you think about it differently in a woman versus a man. So we've actually seen lots of papers on prognosis with coronary CTA looking at just the overall anatomic findings of obstructive disease. You can see non-obstructive disease, 1, 2, 3, and 4 vessel disease, both uniquely and extensively and very effectively able to risk stratify women and men as based on the CONFIRM registry, which Quanta will be participating in the next CONFIRM 2. Anybody who would like to participate and does CTA, you can talk because we're starting a second CONFIRM registry shortly, which will be focusing largely on the detection and quantification of plaque, so it'll be very interesting. But what's also interesting is with CT is we're able to look at some unique factors which have been identified as precursors of an acute coronary syndrome, precursors of major coronary disease events, positive remodeling, low Hounsfield unit or dark plaque is more non-calcified plaque, a napkin ring sign, which is a sign of the thin cap fibroatheroma, and spotty calcification. All of these are uniquely found with intravascular ultrasound, and we actually have emulated and validated these findings extensively with CTA. Here's some data from PROMISE, just over 2 years, able to risk stratify. Now, what's fascinating about these high-risk plaque features? Again, I'm going to pause. What's fascinating is that they're more predictive in women than they are in men. They're more predictive in younger patients, and they're more predictive in patients with non-obstructive disease. So we, again, have to expand our thoughts and our ideas about what is risk and start to encumber some of these very important findings, which we're learning from our interventionalist colleagues in order to bring into the world of CT. Fascinating findings. And if you haven't read these 2 papers just over the last couple of years, there have been 2 dedicated papers, position statements, expert consensus statements from the American Society of Nuclear Cardiology, led by Viviane Ticchetti and myself, looking at myocardial perfusion imaging in women, kind of a state of the evidence, really well done by Viviane taking the lead on this. I was pleased to be a part of that. SCCT, the Society of Cardiovascular CT, just this year also published a coronary CT imaging where we talk about a lot of factors, including the use of CT in pregnancy, structural heart, et cetera, lots of other areas which you might be of interest in, and as well talking about atherosclerotic plaque. These can be very helpful if you hear somebody talk and then you want to go back to get a little bit more detail. 2, I think, very timely papers on the subject. So with 1 minute left, I'm going to try to explain this slide. So to answer the question, and most of you are sitting there saying, she didn't really answer the question. She just kind of danced around it. And I did, but I didn't. One of the factors that I want you to introduce you to a lot of unique novel risk markers, which I hope gets you thinking. You know, we show up, we turn the light switch on, and we do our work, and it's da-da-da-da-da. Well, the science is always moving. And the science has really unearthed a lot of very novel factors. There's a lot of risk in non-obstructive disease, a ton of risk. I have some data I'm working on right now that shows that we actually have myocardial ischemia, we have FFRCT, and we actually have invasive FFR, and we're documenting ischemia in the setting of non-obstructive disease. So there is real non-obstructive disease that is associated with ischemia and at risk, as well as microvascular dysfunction should always be in your mind with any woman, even if she has non-obstructive disease or normal coronaries or obstructive disease, as well as for your male patients as well. If you start to think about atherosclerosis and probing some of this relevant biology, I think you'll be able to more effectively care for your patients, whether you start with a perfusion study or a CT or a calcium study. Think about bringing in the relevant other pieces of biology that can round off in order to effectively answer your questions. And of course, intensify and guide and be very intensive of your care of female patients. Thank you very much.
Thank you, Dr. Leslie. Our next speaker is Professor RAFFAELE GIUBBINI. He is a full professor and the head of the Department of Nuclear Medicine in the University of Brescia in Ospedale, and his research interest is in myocardial PET-CT and myocardial quantification of blood flow. His lecture will be about the absolute myocardial blood flow measurements, PET-CT or CZT. Thank you, Professor RAFFAELE.
Thank you, Claudio. Distinguished Chairman, dear colleagues, let me first thank my friend Joao Vitola for this invitation in this excellent meeting. These are my conflict of interest disclosure. It is well known that there is a modest relationship between stenosis diameter and functional evaluation of myocardial blood flow, with marked scatter around the regression line. And this is true for the overall population, for the left main, and for different coronary arteries territories. In several presentations in this Congress, Dr. Shaw has shown that management driven by anatomy versus medical therapy showed no input of outcome, whereas management driven by flow physiology versus anatomy impact positively on outcome, as well as physiology-driven versus medical therapy. There are different factors affecting myocardial blood flow measurements. As previously underlined, the FFR is a measure between two different pressure and required to abolish the vascular resistance that is not easily achievable, especially with the dipyridamole, but also with the adenosine and regadenoson. And furthermore, the FFR cannot consider the microvascular resistance. This is a big difference with myocardial flow reserved measured as a ratio between myocardial blood flow during hyperemia and myocardial flow at rest. And several factors can affect the myocardial blood flow during hyperemia. Risk factors, and you see that the myocardial blood flow during hyperemia is lower in presence of risk factor like diabetes, hypertension, smoking. And in hypertrophic cardiomyopathy, the myocardial flow reserve can be reduced due to a high rest blood flow. And therefore, there are several limitations in measuring the blood flow with the FFR. First of all, is a vessel-based lesion-specific index. Its application to diffuse disease or multiple stenosis in the same vessel is limited. The FFR cannot be measured in total vessel occlusion, And in chronic total occlusion, FFR in a collateral donor artery is lower than in case of no collaterals. As previously underlined, FFR assumes an intact microcirculation and normal response to adenosine, and this is not true in presence of hypertension, left ventricular hypertrophy, smoking, hyperlipidemia, diabetes, left ventricular dysfunction. And first of all, FFR is not a measure of peak flow. And it has a high cost, no reimbursement, and used only in less than 10% of PCI procedures. And if you want to quantify something, we have to use units recognized by the International System of Units. So even myocardial flow reserve is not an absolute quantification of myocardial blood flow. Myocardial blood flow must be measured in milliliter per minute per gram of tissue. And we know that the rest, myocardial blood flow measured by ammonia is around 0.7, 0.8 milliliter per minute per gram of tissue, and during hyperemia is 1.7 milliliter, at least 1.7 milliliter per minute per gram of tissue. When we apply a stress test to a patient, both pharmacological or exercise stress tests, we induce microvascular vasodilation and therefore flow maldistribution that can be measured quantitatively by PET, semi-quantitatively by SPECT, and relatively by flow fractional reserve. Ischemia is related to the imbalance between myocardial blood flow and metabolic request. But we have to keep in mind that ischemia is not an hydraulic phenomenon, it's a metabolic phenomenon. With reduced oxygen, fatty acid, and glucose to the myocardial cell, reduced the production of ATP because of the impairment of glycolysis and the increase in lactic acid concentration and therefore tissue acidosis due to the impairment of the Krebs cycle and increase of hypoxanthine due to the low metabolism of ATP and finally reduced nitric oxide release and increase of the release of endothelin with contraction of the epicardial arteries. And we have only two ways to measure ischemia. The trigger of ischemia, that is inadequate myocardial blood flow and coronary steal, and the consequence of ischemia, that is the ventricular function impairment due to myocardial acidosis. This is, therefore, not surprising that stress echo has a lower sensitivity because stress echo is measuring real ischemia, the metabolic phenomenon, the regional wall motion abnormalities induced by acidosis. Whereas, for instance, PET is measuring the maldistribution of flow. But PET, with the dynamic acquisition, can measure both flow at rest and after maximal vasodilation. In this case, we see a perfusion abnormalities of the lateral wall, and there is about an impairment of hyperemic myocardial blood flow in the territory of the left circumflex, and an impairment of the coronary flow reserve that is clearly below 2. What is the problem? We know that the combination of measuring the absolute myocardial blood flow during hyperemia and myocardial flow reserve contributes to the prognostic evaluation of a patient. If both are reduced, you see in the lower left quadrant that the number of cardiovascular death is very high, but there are also patients, for instance, patients with normal myocardial flow reserve have the abnormal myocardial blood flow, and patients with preserved myocardial blood flow during hyperemia and low myocardial flow reserve, like patients with hypertrophic cardiomyopathy. Therefore, both the parameters contribute to define the patient prognosis. But this is a problem of with ammonia, that it requires a cyclotron, it requires a module, radiopharmacy, and a module for purification, and of course it requires PET. With the CCT camera, due to the characteristics, you see here the CCT detector. This is very small in comparison to a traditional photomultiplier. The size of the detector offers the possibility to create a geometry that is really very similar to that of PET, thus allowing a dynamic acquisition of the tracer uptake in the heart after administration of the tracer. This is the same patient seen before. You see that, again, we can see the perfusion defect in the lateral wall and an impairment of hyperemic myocardial blood flow at the abnormal blood flow reserve. This is a case study of a patient. It is clear a severe perfusion defect in the LAD territory. But look at the flow measurements. There is a reduced in the myocardial blood flow during hyperemia, but a normal myocardial flow reserve. Why? Because the flow reserve at rest is the flow at rest is very low, and therefore the myocardial flow reserve is normal, but it is clearly an abnormal study. The same patient evaluated by the CCT, we have a perfusion defect in the LAD territory, and you see same value of myocardial blood flow at stress in the LAD territory, and normal myocardial flow reserve due to the very low flow at rest. We have just completed the recruitment of more than 50 patients evaluating the myocardial blood flow and myocardial flow reserve with the CCT SPET in comparison to ammonia PET. This is the relationship between myocardial flow reserve and hyperemic myocardial blood flow. the ability of CCT evaluation to predict a stress myocardial blood flow below 1.7 is around 86% with the sensitivity with 66% specificity and 84% to predict a myocardial flow reserve below 2 with the 63% specificity. And you see that in this calculation, it is important to use the attenuation correction in CCT. Without attenuation correction, both sensitivity and specificity are suboptimal. Finally, the accuracy of PET-CT and CCT to discriminate patients with ischemic heart disease versus normal subjects is quite good. You see that we have same values of a stress myocardial blood flow for PET and CCT, although the myocardial flow reserve is a little lower for CCT in comparison to PET. In conclusion, with the CCT camera, we can obtain reliable measures of myocardial blood flow and myocardial flow reserve. A correct methodology implying cross-talk subtraction of residual activity, motion correction during dynamic acquisition, partial volume and attenuation correction is required to obtain physiological myocardial blood flow values. This allows to obtain a correct measure of myocardial blood flow during hyperemia that is a strong prognostic predictor in association to myocardial flow reserve. The correlation between CCT and PET, although significant, is not perfect, and therefore CCT cannot be presently considered as a full substitute of PET for myocardial blood flow measures. However, it could be a useful tool for evaluating the results of medical treatment and revascularization procedure in patients with coronary artery disease and in patients with microcirculation impairment in repeated studies. And thank you for your attention.
Thank you, Dr. GIUBBINI, and Dr. Shaw and Einstein for very enlightening presentations. There is no time scheduled for discussion, and it's time for us to move to this quick answers to relevant questions session. So we'll move ahead with that. So thank you, everyone, for your time and attention.